So thank you guys for allowing me to come speak to y'all today. Like Dr. Young mentioned, I work with specialty contact lenses at Baylor, so I get to work with all these awesome doctors and utilize this really neat technology to help a variety of different patients. So how many of y'all have heard of scleral lenses or PROSE devices? Okay, that's actually a good number of you. So interestingly enough, the scleral lens design was actually the original contact lens design created. Back in 1887, they used to use hand-blown glass to create these shells that would go over the entire ocular surface. Needless to say, that was not very comfortable and did not do really well. So over time, with new technologies, we developed the corneal rigid gas permeable lens, which some of us may know about. This is an oxygen permeable lens that goes on the cornea of the eye. And then, of course, we also got our soft contact lenses, which a lot of us are very familiar with, definitely is the majority of the market today. But about 30 years ago, they decided to take that same oxygen permeable material that they used for the corneal lens and redevelop the scleral contact lens. And in the past 10 years, we've actually seen a huge increase in popularity with these devices. So let's first talk about what a scleral lens is. If you can see in this picture here, you can see that this lens actually goes over the entire ocular surface. So it goes from the sclera on one side all the way to the sclera on the other side, really covering that whole eye. In between there, over the cornea, it actually vaults over it, so it's not touching the cornea at all. What goes between the lens and the cornea is actually a layer of liquid that creates this tear reservoir. That liquid is a preservative-free saline, so when we put that lens on, we actually fill the lens up with that liquid, put the lens on, that liquid stays on the eye all day long until you take the lens off. So before we go further, I'm going to talk about what PROSE is. So PROSE actually is an acronym. It stands for the Prosthetic Replacement of the Ocular Surface Ecosystem. It's a mouthful. I'm glad we can just call it PROSE. But it's basically a treatment. It uses a scleral shell to cover the whole eye and treat a variety of corneal diseases. So what a PROSE can do and what a scleral can do are very, very similar. There are some differences that we'll talk about later, but the overall use of it is kind of the same. Both of them are larger in diameter. They range from about 15 to 19 millimeters up to 24. You can see in that picture here, where we're looking at comparing it to a smaller corneal lens, it's a lot larger. It's designed to vault the highly sensitive cornea completely and land entirely on the conjunctiva over the sclera, and it creates this post-lens tear reservoir and also has a new smooth optical surface. Oh, let's go this way. So because of this design, we found it to actually be really useful for a variety of different conditions: irregular cornea, ocular surface disease, different lid abnormalities, and this is because of the benefits that the lens provides. So first is improvement in vision. So a study has shown that 69% of eyes that were deemed uncorrectable with other lens modalities actually did really well with the scleral lens. This is because of two factors. One is we now have a new smooth front surface over the eye with this lens. If you think of a camera, right, if you have a smudge or a water droplet on it, the light's going to scatter, it's going to go all over. That's what our patients that have these really irregular eyes deal with. The light scatters all over, they can't get good, crisp vision, and having this new smooth surface helps enhance the vision. Secondly is that we have that tear layer underneath that actually neutralizes any corneal irregularities. And that's really the key in what improves the vision with this device. So if you think of, I'll have patients come and they'll say, well, how come I can't get this vision with glasses? Well, it's because you're working with a glass lens and then you're working with your cornea. It's two different things. This tear layer actually acts as a binding tool. It brings those two surfaces together, creates one new smooth optical surface, and really enhances the vision, which you can see in that picture down there. The first picture shows what the eye would see with no lens, with a patient that's suffering with a severe irregular cornea. The second picture shows what the vision would be like with the scleral lens on the eye. So you can see it's a lot sharper, darker, and crisper. The second benefit of these devices is improvement in comfort. So a study showed that 75% of patients fit in a scleral lens got improved comfort compared to their previous lens modality. This is because this is the only lens that has no contact with the cornea. As Dr. Weichert mentioned, this is a highly innervated tissue. It's very sensitive. We can all think of when we got an eyelash in our eye and it gets to the cornea and it just drives us crazy. And this lens doesn't come in contact with that at all. And it lands smoothly on the conjunctiva over the sclera and allows to have a very comfortable, stable fit. The last benefit, which is probably the most applicable to what we're talking about today, is the ocular surface protection. So once again, those same design factors that helped us with the first two things help us here with ocular surface protection. We have that hard shell on the outside that really helps shield the eye from our external factors. It shields the eye from the lashes in certain conditions that are rubbing against the cornea. It shields it from the dryness, from air, from wind, and really makes a very comfortable, protected surface. The second benefit is the tear reservoir. This keeps continuous lubrication on the eye all day long using that preservative-free saline. We all know when we use artificial tears, it feels good in the moment, but 30 seconds, a few minutes later, that relief kind of goes away. This lens allows for continuous relief all day long when that lens is on the eye, and in turn allows the eye to sort of heal, the cornea become more stable, and reduces some of the symptoms of dry eye. So this is an example of a patient that suffers from dry eye, and they came to get fit with the lens. Usually when I see a patient, I put the lens on in the morning, have them go out to the waiting room, and I see them back a few hours later. As you can see here, just after a few hours, those dry spots that are there are almost completely gone just after a few hours of having that lens on the eye. The patient was already feeling a lot better and doing a lot better, and that's just within a couple hours. Over here, we have a patient that's suffering from dry eye secondary to Sjogren's syndrome. You can see those dry patches all over the cornea. You can see, of course, an increased blink rate. They look pretty uncomfortable. We fit them with this lens that has that tear layer you can see as we're scanning across that covers the entire eye. And after a week of wearing the lens, well, let's see what it looks like after a week of wearing the lens. There we go. So you can see there that cornea has completely cleared up. The cornea has no dry patches. It almost just looks like there's nothing there to see because it's all been cleared up. And that's just a week of wearing the lens. Of course, there are more severe eye conditions, more severe dry eye, like pemphigoid. This is a severe type of scarring and dryness that can happen. You can see that there's some keratinization in that top picture, and the bottom picture actually has an area of severe thinning because the eye is just so dry. This was a much more challenging fit, but after a year of wearing just this lens, they basically have, the surface has completely cleared up. Oh, let me go back here. This clicker is difficult. Let me just use this one here. So you can see here that the dry patch has gone away, that area of thinning has refilled, and they have a much more stable ocular surface. Obviously, this is a really severe case, and it's going to continue to take more and more time for this cornea to fully heal, but it's already on the right track. The last thing we're going to talk about is persistent epithelial defects. This is when the cornea basically breaks down. You have a scratch on the eye, you have an area that just won't heal, won't come back together. It's very painful, very uncomfortable. And there's a variety of different methods to help them heal, but certain cases just don't get better. One of our research fellows did a study on this. We looked at 8 patients that had a non-healing defect ranging from 14 days to 245 days. They tried a variety of different methods, and they just were not healing. When we fit them with the scleral lens, after about 11 days, all of them fully healed. So the bottom 3 pictures show an example of that. The first picture shows the patient when they first came to see us. They have that area of thinning, that defect in the middle of that eye. After a few months of a variety of different treatments, you can see that it hasn't changed a whole lot. It looks kind of the same, maybe a little bit better. So we fit them in a scleral lens, and the last picture is after a month of wearing the lens. It's completely healed over, the patient's doing a lot better, and we're continuing to manage them with that lens. So after hearing all the benefits, we can kind of see why we can use it for so many different conditions. The regular corneal condition allows us to get better vision with the lens. Ocular surface disease, we have that continuous lubrication that makes the eyes much more comfortable. We have seen some benefits in normal corneas, but it's a little controversial because it is a very extreme lens for an eye that might not need it. And of course, we've seen benefits with lid abnormalities as well. What we don't see on the list is, of course, blepharospasm. But with what we're starting to see, we do think that this is something that could be added to that list of benefits. So this is kind of basic. We all sort of know this. It's a chronic condition that progressively worsens over time. There are several treatment options, Botox being the best, but of course, that treatment doesn't last. We have to go back for continual treatments again and again. And of course, dry eye commonly presents with it as well. It has similar symptoms like burning, grittiness, light sensitivity, and that's where I come in. So because these patients are suffering from severe dry eye, a lot of times they get sent for PROSE or sclerals. So this is, of course, what I see when the patient first comes in. Let's see if this is, oh. There we go. So of course, we see that extreme blink rate. We see that discomfort. We can see the patient's pretty uncomfortable. something that I know a lot of us here have experienced and are very familiar with, and obviously something that we want to help. So when they come to see me for a scleral, the way it starts is I start with a trial lens. So I take this lens, I fill it with that preservative-free saline, and I actually dip a fluorescein strip in there. You all know about that fluorescein dye. I use it with my lens to assess the fit. This is kind of standard practice across the board with sclerals. It allows me to see how the lens is sitting and what I need to adjust. But what we started to notice with this fitting technique is this. So this is not a still photo. This is a video. This is how much that blink rate has reduced with just that lens on the eye. The patient looks a lot calmer. We don't see that brow as furrowed as before, and she just appears to be a lot more comfortable. So this is something that myself and Dr. Yen and other doctors in our clinic all started to notice. So we were all seeing that. We were sending more patients that were suffering from blepharospasm to get fit in this lens, but we didn't have anything to quantify it, to actually say that, yes, this is helping, this is making things better. So I used our blink rate machine to start measuring it. So that very stylish headgear you see there that I decided to model for us is actually a device that helps to measure the blink rate. So it detects just the number of blinks that are going as that device sits on the eye. So I started incorporating this into my scleral fitting. I said, what was the blink rate like before I fit the lens? What is it like when I first fit the lens? And what is it like when I put fluorescein under the bowl of the lens? I only recently was able to start doing this because we only recently got that instrument up and working, so we do have a small sample size here of only 6 patients. But we do have one patient that actually was suffering from blepharospasm and was undergoing Botox treatment at the time that she came to see me. And excitingly enough, we actually did see a decrease in the blink rate. So you can see the red columns there. That's that's the patient with no lens on the eye. All of them tend to have a pretty high blink rate. When we go to the orange column, that's with just the lens, no fluorescein on the eye. For the most part, we can see a pretty good reduction in the blink rate. We do have one patient, patient number 4, they actually had a little bit of an increase, about 1 blink per minute. So basically no change there. But then when we went to the lens with fluorescein, they all continued to have a reduction in the blink rate. So on average, we saw that with no lens on the eye, our patients had about 30 blinks per minute. With the lens alone, it went down to 16 blinks per minute. And then with the lens and fluorescein, it actually went down even further to 10 blinks per minute. So when we look at the percent reduction, we saw that having no lens on the eye to then the lens, we saw a 47% reduction in the blink rate. Going from the lens to the lens with fluorescein, we saw another 51% reduction in the blink rate. And then when we compared no lens to the lens with fluorescein, we saw a 73% reduction in blink rate. So it's pretty clear here that having the fluorescein tends to do a little bit better. Something that fluorescein is doing is causing the blink rate to go down even more, but even the lens itself is helping a significant amount. So now, we still have a lot of questions, a lot of things that are TBD, to be determined. So of course we need to increase our data pool. This was only 6 patients. We only had one that was actually experiencing blepharospasm, and that was their main diagnosis. So we definitely want to get more patients. So as we now have this device, I'm hoping that more and more patients, as they come in for this scleral fit, will start to measure these blink rates and have a lot more information that we can share so we can have a better answer of what this lens is doing. Of course, the next question is it the PROSE or the lens itself that's helping, or is it the fluorescein? We did see a greater reduction in blink rate with the fluorescein, but if you actually see our one patient that was suffering from blepharospasm, they had a big drop just going from no lens to the lens. When we added the fluorescein, they didn't change that much. However, we have other patients, like patient number 4, that needed the fluorescein to get a much lower blink rate. So we really want to look at this a little bit more, see which one is actually helping, which one do patients actually need. And if it is the fluorescein, what is it about it that's helping? Is it a filtration effect, or is it the actual molecules of the fluorescein that are helping? Some of you guys already know about the filtering effects of the rose-tinted lenses. It helps block out the green and blue wavelengths in the light spectrum, and that can be very calming and relieving. But obviously that looks very different than the dye we're seeing with the fluorescein. So if it is a filtration effect with the fluorescein, is that something we can put in glasses? Is that something that we can give to our patients to start to help? And if it's not the filtration effect, is it the molecules? And if it is the molecules, is this safe to put on the eye for a long term to have patients wearing every single day and hopefully provide some relief? So these are all things that we're hopefully going to work on and get some more information as time goes on. So now that we've heard about all the great things about the two, we're probably wondering, well, which option is better? Is it the sclerals or is it the PROSE? Now we talked about before, the concept between them is pretty much the same. They both are creating a new transparent, smooth ocular surface over the eye that helps irregular, damaged, or diseased corneas. And they both have that tear reservoir that provides that constant lubrication throughout the day. The main differences are, one, where can we find this lens? PROSE is limited to the PROSE facilities and the PROSE sites, and there's only 12 throughout the countries. So if you're not in Houston or one of the other cities that has a PROSE clinic, you are going to have to travel to go there. Your patients are going to have to travel to go there. We have patients that travel all the time. Patients travel to Boston to get fit in the lens, but it can be a little bit more work to get to where this lens is. With the scleral, it's provided almost anywhere. A lot of optometrists are fitting sclerals, and a lot of them are fitting them really, really well. Now, I would keep in mind that not everyone knows exactly what they're doing with these lenses, and they are a little bit complex. So a great reference tool is the Scleral Lens Education Society. This group actually focuses on educating patients and practitioners on this device, and they actually have a page that talks about where you can find a practitioner that can fit this lens. And the doctors on their website have demonstrated an enhanced knowledge base on these lenses. Now, keep in mind, just because someone's not on the site doesn't mean that they don't know what they're doing. It's just a way to demonstrate that these people for sure know what they're doing with these lenses. The second key difference is the design and fit. So it's all about how much tailoring or customizing your patient needs with this lens. Both of the lenses are extremely custom. Scleral lenses are ordered specifically for the patient, as PROSE are ordered specifically for the patient. But the difference is the level of customization that we can get. So a traditional scleral can get up to 2 haptics or 2 meridians of curvature. So if you think of astigmatism, how it has 2 powers to correct the eye, it's kind of the same thing. And we can do that with a regular scleral lens and get a pretty good fit with just that. However, there are some cases that need 3, 4, even up to 8 meridians to really get a good fit. And that is where the PROSE comes in. That's where we need these full 8 levels to really customize that fit, get it to be really comfortable and really successful for the patient. And with the PROSE, we're able to do that. So like I said, the similarities and the benefits are essentially the same. It's just a matter of where you can find it and if that level of customization is needed. So are sclerals and PROSE the key to success? Of course, I'm a little biased because that's what I work with and I think it's great. But the Boston Foundation for Sight has actually done a lot of research on this and found that almost every condition out there does extremely well and is extremely successful with this device. And they saw on average there was an 80% significant success with just the BostonSight PROSE. As you go down the list, dry eye had a 77% improvement. Ocular complications with SJS had a 90% improvement, GVHD 76% improvement, and the list goes on. And hopefully with further research, we can add blepharospasm to that list as well. So